Okay, cool. So seeing a lot of high blood pressure, and it's good to know that everyone knows it's in pregnancy. So this is the World Health Organization definition of it. Blood pressure over 140 systolic or over 90 diastolic, and protein urea. So do you want to know what that is?
Yeah.
So protein coming out in your urine. For us that's a bit irrelevant, or paramedics it's a bit irrelevant because we can't do urine dips or anything like that to test it. So it'll mostly be going off with blood pressure. Whereas if you happen to be with a PP that day, you can maybe ask him to do a urine dip just for your own interest. So that's what most people tend to know it as, and not really know if it goes any further. I've asked loads of different professions and everything, and you always get the same sort of definition. But thankfully I asked one consultant in obstetrics, and they gave me a bit more. So it tends to affect nulliparous women, so they're firstborn, they've not had a baby before or anything like that. So they're the highest risk factors, and you've also got very little information on them about what they're like in pregnancy, what their numbers tend to do. It affects obese women, very much in that category, so much higher percentage than anyone else. Geriatric mothers, so if you're over 35 and having a baby, you're at a much higher risk. And also those under 20, so you've got much smaller volume that you tend to have, and be like, you're more like prone to it. Does anyone still copy? So we'll go over basic female reproductive anatomy. So going from where the egg's fertilised, ovary produces the egg, taken in by the fimbriae, taken into the fallopian tube, where it's then fertilised. And it travels its way around, multiplying in cells and dividing as it goes round. So like this, throughout the days. And then you've got 3 layers of the uterus. So the most internal to the body is the perimetrium. Then the myometrium is the thick muscular part in the middle. And then the closest to the fertilised egg will be the endometrium, which is the bit that we'll be interested in. So as it comes round and enters the actual uterus, it's got this shell of cells around it called trophoblast. So just that outer crust. And those are the parts that get the body ready, the uterus, ready to bear a child and develop a placenta. So on the 8th or 9th day, they hatch away from the egg and start to bear into the endometrium. So they break away all the cells here and make just massive channels that blood can flow into. So these are the channels here. This is a bit more progressed on, so you've started to get a placenta. But as the trophoblasts break away, they'll dig into the endometrium, which will end around here, and cut away all of this, so that blood can just dump into it. So obviously, the baby will need so much more blood flow than the normal uterus would need. And then in the pregnant uterus, you've got these arteries here that go from the endometrium into the sac of the placenta. And so they're called spiral arteries by the shape of the helix shape they have. And now, don't worry, it looks scary. I love scary diagrams, but I like making them look nice to understand. So this is your normal histology or cross-section of a spiral artery. So when you're pregnant, like I said, you need this massive blood flow. So the trophoblasts come in and they eat away this muscular part of the artery. Does everyone remember their GCSE arteries and stuff? Right. So we'll go over it. So you've got smooth outside, which protects everything. As you come inside, you've got a really thick layer of muscle, which is what keeps your blood pressure up. So it can squeeze tight and raise your blood pressure, or it can loosen off and drop your blood pressure if it's getting too high. But the trophoblasts come in and they eat away all of this to make your artery that much wider. So there's no blood pressure control on it, it just dumps the blood in. So this is, although it looks not circular like you'd expect an artery. This is what's normal. But in pre-eclampsia, the trophoblasts struggle to get into the artery, so they can't eat away any of this tunica media, or the thick muscle, and you're left with that tiny little lumen, which is why the blood can't get into the placenta. So the placenta then panics and releases loads of inflammatory molecules called cytokines. So it'd be nice if they could stay in the placenta and do their job, but obviously they go around the body and cause all sorts of problems. So what do you get when you've got an allergy and it goes all red? What's that called? Starts with inflammation. Yeah. So you get widespread inflammation around the body, and some of the molecules that go around damage the junctions between your blood vessels. So going back to here, all of this inside layer of your artery is endothelial cells. So they'll all press together, and that'll stop the big molecules, but it doesn't stop fluid leaking out. Stop me if there's anything you want to go over. So to stop fluid leaking out from where you've just got these cells pressed together, you have all of these sort of chemical junctions. I wouldn't be able to tell you what different ones are and everything, but just the fact that they're there, and they stop the rest leaking out like a hose pipe that's had holes stabbed in it. So, like I said, I like my horrible diagrams, but you don't need to know any of that. So the thing that the inflammation gets rid of is stops the production of vascular endothelial growth factor. So that's the thing that starts the cascade and regenerates all of this. So it just keeps making more and more to keep it up to date. But then that gets stopped, and so all of this stops as well. So your junctions between those cells start to break away. And what happens when you get leaky blood vessels? Swelling. Why do you get swelling?
Because it pulls in the area.
Yeah. Does anyone know what it's called when you get the fluid coming out?
I do.
Edema. Yeah. So you've got fluid leaking out of your blood vessels into the space around it. You've got edema. So what sort of places can we get edema? Ankles. Yeah. So why does that happen? Yeah, so the most difficult place we see it is in heart failure. So there's not enough blood pressure to get the fluid back up the body. So it all starts to leak back down into the ankles with gravity. What other places can we get it in?
Fingers?
Yes, fingers, yeah. So coming down with gravity again. Is there anything, anywhere, so a lot of the time we turn up to people and go, cool, you've got a bit of edema in your ankles, haven't we? What are the places that we really don't want them to have edema? Lungs, yeah. So you've got loads and loads of veins and arteries around your lungs, because that's how the oxygen gets into our body. But you start to drown if you get edema coming out of those vessels. So, my lovely artery there. So you're basically drowning from the inside. It's the same as if you have pneumonia. Okay, and along with the edema, you also get loads of other factors released with the placenta that cause vasodilation. So you lose vasoconstriction, so you lose all your vasodilators and your vasoconstrictors go up. So not only have you now got edema, you've got edema under pressure, so you get loads and loads of it. And you're more likely to get it in a place that you don't want it. So placenta gets scared, we'll go back over it. Placenta gets scared and released inflammatory proteins. The junctions don't get maintained, which causes fluid release from the damaged blood vessels. So it's like you've just got a hose pipe with all your blood going through it and stabbed holes in it. And that gives you your edema. And then you've now got loads of vasoconstriction all over your body, which raises your blood pressure, which is why you see it on the monitor, and the mother's blood pressure is really high. And then you have edema under pressure. So that was a little bit quicker than I thought. So
Can we just go back to that?
Yeah. Is there any bit you want to go over?
All of the information usually.
So, where you should have this massive channel that has just been dug away for blood to go into the placenta, it doesn't happen. So these cells that should get into it and eat everything away don't manage to, and you've got this tiny little artery. So where the placenta should be getting just loads and loads of blood dumped into it, instead it gets a tiny little small flow and it panics. So it releases inflammatory proteins.
Why does that happen, or are you going to tell us that?
No, so the placenta is expecting a lot of oxygenated blood, but it's only getting a tiny amount. So like in an allergy, where you get your bright red skin and everything, where you're getting inflammation, it thinks, oh, that must be enough to fix it. So if it releases those proteins, it thinks it's going to get more blood flow, which it probably does, but unfortunately they travel around the body as well and cause other problems.
So is it like the placenta's sending the panic signal or the body?
That's it, yeah.
The placenta itself.
So the placenta is expecting loads of oxygen and it's not getting it. So it's sending off a signal to say, I need more oxygen.
Okay, that sets everything else up.
Yeah.
Okay.
Also,
Vaso is like a vascular space. So if it's something that opens up your blood vessels.
Okay.
Everyone happy? Everyone happy to go on or need a break? Okay, so that's all great. It explains the high blood pressure because all your blood vessels around the body have tightened down. But it doesn't explain to us why you're getting protein in your urine. So we've all done anatomy of the kidney. So okay, so the basics are it all comes in through the blood filtration system. You get to these pyramid things where they filter out all the toxins and everything and send it into your ureter, which is just a channel straight down to your bladder to be excreted out. But the problem comes with the fact that we've now got these chemicals travelling around the body and damaging our blood vessels, poking holes in them. So proteins that should be travelling through in your blood to keep all the fluid in there are leaking out with the fluid as well. So as they cross over your ureter and your pyramids, they're just dropping into it. So it's more of a diagnostic thing to show, oh, you've got protein in your urine, that shouldn't be there, rather than anything to say, you've got protein in your urine, let's panic. But yeah, it's dropping in there, going down to the bladder, and coming out. And so when you do a urine dip, it's showing up on the stick. So again, we had our locations of edema. It goes down to your legs, your lungs, and there's one more space that we really don't want it going into. Anyone think of it? No, it's all right. It's all right with your heart, so I guess it's already in the blood.
Brain.
Brain, yeah. So cerebral edema. So what happens if you have someone in major trauma? What would we be calling HEMS to come and do? So if we've got someone who's had a massive whack to the head, we're worried about them bleeding. So we call HEMS or the air ambulance to come in, give them an anaesthetic to protect the brain from the pressure in it. And if we have edema coming out in the brain, it's basically the same as having a bleed inside your brain. So it's putting extra pressure on everything. And we all know that the brain's quite a high maintenance organ. You can drink loads and your liver will probably shrug it off in the morning and just give you a bit of a hangover. But if you put pressure on your brain, you'll start fitting and doing weird and wonderful things, losing your vision. So, has anybody been to somebody with pulmonary edema before? No. So I've only been to it once, but they sound really bubbly. As soon as you walk into the house, you can hear them crackling away. And they tend to have massive desaturation, because obviously it's like you're drowning from the inside. So where that oxygen should be getting to the blood vessels, it's just hitting the fluid and not doing a lot. And they'll probably try and cough it up as well, because of the irritation inside your lungs. So ways you can get rid of pulmonary edema. Obviously the first thing you can do, really nice and easy, lay somebody in a 30-degree position and let all of that fluid slide down to the bottom, so you've at least got some of the lung that can work. You can obviously blast them with oxygen, because the air that's getting in, you want it to be useful. So make it as high a concentration of oxygen as you can and just try and get those sats up. But they're going to be in quite a poor way. And normally we go to people that have had what's called cardiogenic pulmonary edema. So like with the legs, where the heart's not pumping hard enough to get that fluid moving, it's just sitting there and coming out into spaces. But the problem with pre-eclampsia is it's poking holes in that hose pipe that's caused it, rather than a lack of flow. So things like furosemide might be contraindicated against using. One thing we can always use is positive pressure ventilation. So CCPs would carry, critical care paramedics would carry a mask just like this that you could put on somebody, and when they take a breath, it will blast some air in as well. So that can push the fluid back into the blood vessels. But unfortunately we don't carry that. So what we have got is a BVM. So you can't really use it on someone who's conscious, because if you've got a pre-eclamptic woman who's drowning in fluid, she's probably not going to be the happiest of patients you've ever been to. So you don't want to go putting a mask over her, clamping her face down and pressing on a bag and forcing air into her lungs. So that one would only really be if they go unconscious from the lack of oxygen, then you can start pushing it back in and you might see a bit of an improvement. Another one we've got, GTN. Anyone know what GTN is? That's it. So the red spray that you get in the bags. It's a bit of a weird one in pre-eclampsia, because on JR Calc it says you can only use it in heart failure, whereas the British National Formulary, so that's what they would use in hospitals. Midwives, have you seen people use it? No? Oh, okay. So in the BNF they don't actually mention it being used for edema. I think one time I looked in it, they had, and they didn't specify why the edema had to occur. So unfortunately we're a little bit limited in our management of pulmonary edema caused by pre-eclampsia, because everything is around heart failure. Yes?
Can we still do it if the evidence is there then?
Yes. Well,
If we can justify it?
I am not that qualified to say go off guidance, but I'm sure you've seen many arguments about that.
I'll ask tonight.
Yeah. You were the CCP?
No, but I'll ask the paramedic. It's been a para for 21 years.
Yeah, so there's this. Have all of you heard about evidence-based practice and this and that? So it's about not going by just the rule book that's in front of you and looking at what the journals say and what looks like the best thing at that moment to do. So this is when you get into lovely arguments like this. So, everyone happy or want to have a coffee break for 5 minutes?
What's, you know the GTN, did you say that's red
Yeah.
spray? Is that like nitrolingual? Was that like?
Yeah.
Yeah.
So
That is,
I
yeah.
called it red spray because it comes in a red bottle. Yeah. So it's glycerol trinitrate. And that's a really strong vasodilator. So the same as so what you're lacking because of the pre-eclampsia, it'll loosen off those constricting arteries.
Is that probably the quickest method to use? Or?
Yeah, the evidence looks like it would fix your problems, and I've had a look at some trials and things where they tried patches of pre-eclampsia to loosen up, to lower that blood pressure over a long term, and it said it was absolutely safe. There had no issues at all, and the mothers showed a lower blood pressure in general, but not critically. So in the future, it'd be nice to see a trial of us using that. Yes.
Sorry, if the arteries are leaking and then you gave GTN to relax them, would that increase the risk of haemothorax if they've got pulmonary OD?
So it wouldn't, the leaky gaps probably wouldn't be large enough to let red blood cells through, but you could very well end up with a pleural effusion. So that's fluid in the pleural space rather than blood. So yeah, it's really not an ideal situation to have preeclampsia. Sort of hit from all angles. So this cerebral edema that we were talking about, it tends to come out in the back part of the brain. So yeah, so you've got, this is getting into neurology here, so don't worry, you don't have to take all of it in. We've got these front bits which do all of your movements and your thinking, like your maths and stuff. And then at the back, you've got what they call like the reptile side of you. So just purely survive, keep breathing, and keep your heart going. So you've got these two are really commonly affected. So parietal and occipital mode, that's just sight, how you feeling stuff. And it's getting really close to the brainstem here, so what keeps you alive. And that's found in every single eclamptic seizure. So, and then they found the front part of the brain was involved in 80% of them, or 80 to 90% of them as well. So as this fluid comes out of the damaged arteries, it's putting more pressure on your brain, which is why you'll find your eclamptic woman in a tonic-clonic seizure. Everybody know tonic-clonic? So shaking around, really rhythmic. The other way you can see it is vacant, so the lights are on but no one's home. But pre-eclamptic women, or women in eclampsia, are just tonic-clonic seizure, shaking. They may stop themselves, but they'll have a recurrent seizure so many times in an hour, and it just stops, comes back, stops, comes back. So you get these little white patches on an MRI scan, which is where all the fluid's coming out and putting more pressure on the brain. And then another way that eclampsia happens, so there's two ways it puts pressure on the brain, is you've got in your carotid arteries that run up your neck and give blood flow to your brain, you've got little bits that vasodilate and constrict. So they let more or less blood into the brain as needed, because you need that really perfect, like Goldilocks blood pressure in your brain. And when you have a stupidly high blood pressure in your body, like you might do in a severe preeclampsia episode, the gates just go, sod this, I'm not bothering in trying. And they just let all this blood dump into the brain. And so the brain tries to protect itself by, so these are your carotid arteries here, and at the point where the brain thinks it's going to get damaged, it just clamps off shut and blocks off blood flow. So yeah, not ideal. So does anyone know what other sort of condition that we go to quite often that it's like? Is that, sorry? Epilepsy. So epilepsy would be similar to your seizure. Yeah. that a lack of blood flow to the brain is also like a stroke. So you've all seen the videos where it says like a fire burning in the brain. So where you'd normally have a clot stopping blood flow, you've now got the body doing it to itself, which is a really clever idea. So all of this blood flow that's coming out of the carotid artery hits this blockage, and you've now got all this blacked out bit that should be arteries filled with blood. So then this part is 2 months later, once they've fixed that clamping of the artery. They probably fixed it on the day, otherwise the person would be dead. But you've now got all of these vessels filled with blood, so like they should be. So, ways to fix eclampsia. Currently on the ambulance, the only thing we've got for seizures is diazepam. So you can give it rectally, which we try not to do, or intravenous. And does anyone know what sort of time period we give for a seizure when it's normal epilepsy? So what's that? 10 minutes. 3 minutes. So it's 5 minutes normally for an epileptic seizure. But in eclampsia, they drop it down to 3 minutes because they want you to really be on the move, get into a hospital with it. So if
do you mean the seizure lasts 3 minutes?
Yeah, so if you turn up to somebody normally having an epileptic seizure, the best thing we do is tend to stand there, watch, and time it. Normally the seizures will stop on their own in a short period, but if they last more than 5 minutes, then you can give either IV or rectal diazepam. And then J.R. Calc says, in the case of women with eclampsia, so if you ever go to a woman that's pregnant and having a seizure, just assume it's eclampsia. So drop that time to three minutes. J.R. Calc says, if the woman has more than one seizure in an hour, you can give that diazepam because it's a recurrent seizure. So that they're a bit more lenient with giving diazepam in pregnant women. And then the other thing you can give is, we can't give it, but in hospital they give magnesium. So there's been a long debate for about 20 years now about whether magnesium is of any benefit or not. And the evidence out there doesn't actually specify whether it stops a seizure. But we'll go on to that in a moment.
Isn't diazepam like a paracetamol, like really strong?
Oh, like a pain relief.
Yeah, pain relief.
So they give it for muscular pain and stuff because it relaxes the muscle and stops it cramping up. I think they give it for back pain, like back spasms. Yeah, but the main thing they use it for in an emergency situation is it's a neuromuscular dampener, so it stops signals getting through to the brain and overloading it. And that's basically what magnesium does, but to a nicer extent. So it stops signals being recognised by the brain and calms it down, and also causes vasodilation, which can get over your clamped off brain arteries. Yes, Charlotte?
Does CCPs carry magnesium?
Yes.
Would they give it in that?
I don't know how happy they'd be to give it, but they can give, or at least here, they can give it for eclamptic seizures. It's specifically stated for it.
Okay.
So, if you turn up to a pregnant woman that's having a seizure and you're quite far from hospital, it's a good idea to either give a CCP a call or HEMS and see if they're happy to come and give magnesium. And from what I've heard anecdotally from midwives and doctors, it will just stop it like that.
So do you think they'd favour magnesium over diazepam?
Massively. So in the UK, places like Canada and America, they will only give magnesium if they can for it, to try and reverse this clamping of the artery, which is one thing, and also it takes away the edema by vasodilation.
Would they also give hypertonic saline?
I've I've looked into this, but I've not actually seen anything that's related to pre-eclampsia for it. I imagine that would be sort of symptom control. But yeah, in Africa, there's a few studies that still use diazepam. So that's about the only information I could get when I was writing that essay. Because where they've got a bit of a poorer healthcare system, they use whatever's on the shelf. And then obviously in any seizure, you need to do your basics well. So keep that airway open, make sure they're still breathing, and check what their heart's doing if they're not shaking around too much. And it may come to a point where you have to call HEMS, not only for magnesium but also to do an anaesthetic and intubation. So this was the trial I was talking about. This is what really got magnesium into the hospitals for eclampsia rather than diazepam. This was done, I think, in 1995 by a massive team of doctors, and they randomised it to you're going to have magnesium, you're going to have diazepam for your seizure, and they used some other ones like phenytoin and other anticonvulsants that we don't really use anymore, and it found that diazepam had 3 times more occurrences than magnesium did. So that's really what doomed diazepam for treating eclampsia in the UK and places like Canada. Does anyone want anything clarified at all? So going back to Menti, we've got a little bit of a quiz. Is everybody on? Is there anyone still logging on to it? And why are they called the spiral arteries? Yeah, it looked like a spiral. So, what was it that happens to them?
The muscle gets eaten away at the inside and makes it bigger.
It's a massive channel, that's it. So, whereabouts? Does anyone remember where the parietal and occipital lobes were placed? Yeah, back of the brain, right by the bit that keeps you alive. Okay, and that is my wafflings about pre-eclampsia. Is there anything that people want clarified at all? Anything to go back over?
Can you get back onto the slide that had the article on it?
Yep. So all my references will be made available in the next few days as well.
Will we be able to access this somewhere?
Yeah, so Joe's wincing there.
We'll-
Somehow
we'll
it'll get
work it out.
uploaded. Yeah. So you'll be able to get the presentation and just a list of every reference I've used. Probably link it to
Oh,
Google
yeah.
Drive on the YouTube.
So how will we get to see them?
So we'll share the YouTube link onto the Facebook, and then if you're on that, there'll be a link to Google Drive or something, which I'm sure Joe's really happy I just said.
Is there a difference between eclampsia and pre-eclampsia?
Yeah, so pre-eclampsia is the long-term condition of having a high blood pressure with protein in your urine whilst you're pregnant, and then eclampsia is that event when you start having loads of seizures in a short period. So you can't have eclampsia if you haven't had a seizure.
So just to check, the seizure is when it gets to the stem, is it? Or is that when it's
Yeah, so so there needs to be pressure on the parietal and occipital lobes, so it causes a seizure, and it's the overload of signals going to the brain where it's got that pressure.
So there's no real treatment for the protein in the urine other than treating the eclampsia itself. It's just used like a diagnostic.
Yeah, that's it.
Basically confirms.
So you can't definitively say they've got pre-eclampsia unless you can do it. But obviously on the ambulance we can have a high degree of suspicion
Yeah.
if they're pregnant and have a blood pressure of 200. Yeah.
So like you kind of like start having signs like you've got the legs swelling and
Yeah.
the hands swelling, and then at what, like if nothing's acted on, at what point would it get to how long will it take?
It's all dependent on the woman themselves.
Like is it something that could take a week, or is it going to be like over a course of 2 days or something?
So the most common time that it actually shows up is very unreassuringly around 3 days after you've had the baby. So you're still not out of the woods for I think it's up to 2 weeks after that baby's come out. But they also say that the only definitive way to fix pre-eclampsia is to get the baby out. So if you're having an eclamptic seizure, HEMS may do a cesarean or something in the street.
Can you confirm what HEMS is?
Sorry,
Sorry.
helicopter emergency medical service, or the air ambulance.
Thank you.
So they're equipped to do a cesarean on the roadside?
Yeah, I don't know whether the person has to be, the mother has to be dead or not.
Okay, so there is
but-
some rules in
yeah.
regards to that.
It's amazing stuff they can do. Like they can cut your chest right open and lift it up to do your heart. But you have to be dead for that as well. There's a real last-ditch attempt. Yeah. Thank you very much for coming, everyone. Hope you've learned something about pre-eclampsia.